We are ready for questions.
Um,
And as usual, people can come up to the microphone. There's already one down there. Go ahead.
I'd like to ask you a question about your private practice, because one of the issues that I run into all the time when I'm talking to practices is the fact, well, it's time. I mean, especially the office managed. Now, you're in a small practice, so you sort of self-manage it and you have your wife as an assistant. But whenever I try to integrate the idea of a screening in, protocol or anything into primary care, it's time, can't be more than 5 minutes. They worry so much about patient flow, which you mentioned. Have you tried to cost this out in terms of the time for the MA doing whatever he or she does and your time to take out that piece, let alone the slight interruption on, because in big practices, that is such a, and do you charge for the testing? Do you get reimbursed for that?
Well, first off, no, I do not charge for the testing or the fitting. It's complimentary, okay?
Wow.
We do ultrasound screening in our office too, which is complimentary. That usually goes between $50 to $500 around town. But we found that if you offer these screenings, because insurance companies aren't going to pay for screenings, okay? So, and patients aren't going to pay for it. If they have to pay anything above their copay or their deductible, they're not interested. All right? But by offering these free services, we're finding so much pathology. The pathology I'm finding from the ultrasounds is incredible. The carotid stenosis I found, the thyroid cancers, the aortic aneurysms, it's incredible the pathology that we're finding. And if you don't look for it, you're not going to find it. So we do the same thing with, we thought, well, we could charge for the audiogram. But, you know, a lot of that's going to be Medicare. Medicare will pay maybe $25 or whatever. And all of a sudden, Medicare is going to see this big spike of my, audiogram reimbursement and stuff. They'll pay for it, and then 6 months later they say, oh, there must be some kind of fraud because you've had so many so suddenly. And then they're going to request all that money back. Well, I don't have cash flow that can do that. So we said, we're just going to do it free, just like our ultrasounds. And the patients love it. I mean, they have no question. I had a guy, he said, you'll never get a hearing aid in me. You can test me, but you'll never get a hearing aid. Cranky old guy. We tested him, and he was surprised at his loss that it looked on the audiogram. And he said, well, go ahead and put a hearing aid in. He says, but I'm not going to keep it. We put it in. You could not take that demo out. He wanted to walk home with it. And he kept him. And to this day, he's extremely satisfied.
No,
so
I
we
agree.
don't charge for that. The cost for me, it really hasn't cost me anything because my EMA isn't doing anything more. You know, it just takes 30 seconds during vital signs. If I had to replace my wife or pay someone to do that, sure, I'd be paying someone, you know, maybe 15, 20 bucks an hour to help with that assistant. But, you know, she fills that gap. So that would really be the only cost for me. In a larger practice, it would fit very nicely. You've got PAs that you could assign, you know, to do these things. And again, it's going to depend on your state because licensing depends, you know, the states control the licensing. And in my state, it allows me to dispense. So, but, you know, you could, you know, in a larger clinic, I think it would work even better because you have more people. It's not going to be as much of effect. It's going to fit in easier.
David Bergeron again from Massachusetts. I think a way to scale up what you're doing, I'd like to suggest that community health workers could really help in larger practices. We're talking about practices with tens of thousands, 50,000. We're working with a practice in Massachusetts that wants to do, the clinicians have 50,000 patients. And in those practices, even the PAs are pretty busy. So I think if you bring in a community health worker who is part of that community, they're hard of hearing, so they share that emotional experience. So they connect at that level. Earlier, I come at this as a CHW. And I was co-founder, I think a way of an analogy with healthcare reform for this, because we're talking about the healthcare system. I was co-founder of the demonstration for healthcare reform in Massachusetts. And we talk about the demonstration project. And we talk about the insurance reform part, but what we don't talk about is the CHWs. If we had not engaged CHWs at the very beginning, we would never have been able to demonstrate it. We needed to do research. We engaged our CHWs. One thing that I might add to Dr. Nicole's, Dr. Maroney's list of things that CHWs could do is they can facilitate and promote participation in research. And I think that's a very important opportunity, especially if we're going to talk about epidemiology and trying to understand the epidemiology better. So CHWs can help with that research. A nice example is I know an audiologist on the North Shore of Boston who has set up her screening booth right in a primary care practice. They have 10,000 patients. The clinicians see the patients. If they identify somebody that they think is at risk, they refer them to the audiologist right there in the office, and the office staff makes the appointments. But she reports that a lot of the patients are still refusing. And she hesitates to call the patients and follow up with them because her fear is that they're going to see me as a salesperson, trying to encourage them to buy a hearing aid. But if you could have as an intermediate step a hard of hearing patient who's been successful at integrating the technology and learning whatever rehabilitative strategies whatever strategies they can use socially to improve their success, talk to the patient before they see the audiologist or the hearing instrument specialist, they can provide that education and counseling. And our experience was that, with the healthcare reform that we would have gotten nowhere without it.
Yeah.
So it's a very important opportunity.
When we started this, I was a little concerned about how our ear, nose, and throat specialists, because we're a small town, everybody knows what everybody's doing. And I was a little concerned about how the ENT would react to us because they dispense hearing aids. They have an audiologist and soundproof booth and all that. And I was concerned about the audiologists that were in town. But a lot of our audiologists that are in the big stores, they're not there full time. They come in from Palm Springs for maybe 2 or 3 days a week, and so they're not there all the time. And but I was concerned about them, well, what's Powers doing? Is he trying to steal our business or whatever? And that's not the case. I mean, we need the audiologist. We need the ear, nose, and throat. We need them for the more complicated ones. But when I looked at this, I'm looking like, well, for the last 25 years, they let all these people fall through the cracks. So we're essentially just picking up those that they've missed, all right? Yeah, they're the easier ones, but they missed them. So, and then your comment about having the audiologist in the office, that will work, but there's still this phenomenon that being a physician, and they hear it from the physician, they just trust. They don't always trust another person. But for some reason, physicians have this whatever, and they just take what we say. Most of them will take for say they just trust it. So if there's an audiologist in the office, sure, the doctor can introduce them and can intermingle with them, but it really helps to have that physician interaction. And that's part of primary care, family practice. That's what we specialize in. Sure, my appointments are only 15 minutes apart, but I may spend 20, 25 minutes with that patient, whatever it takes to get through the problem. I'm not going to say, oh, gee, that's all we have time for, make another appointment. So that's part of our approach is, we're really patient-oriented, and we take the time to explain things.
Oh, my turn. Whoa, that's a pretty loaded talk here. But one question on the teleaudiology. So, what do you think is happening with licensure laws as it relates to where, because I guess the question becomes, if I'm in Florida and my patient is in Washington, where does the law stop? Because there's a licensure that you are treating the person in Washington at that time.
Yeah, I simply don't know.
Okay.
Yeah, I don't know. That's
Yeah.
why it wasn't underlined, because it was something I couldn't address. I don't know if anybody here.
Oh, that's a challenge, I think.
Yeah, it's a huge challenge.
It's a huge challenge. Now, Europeans, because we see a lot of international patients, and we Skype a lot, and we do some of this, and some of the manufacturers have the telehealth option on their processors that you can do through the phone.
Right, and many other countries. I mean, there are teleaudiology programs established in Brazil and South Africa and Australia.
I know,
and
this
don't
is the
think these
US, though.
licensing issues come up. It's a US problem.
No, that's my point. So I think that who's stopping us from doing this? Because I think a lot of our patients would benefit greatly. So if there's anybody that has any, idea or any thought of what's happening with state licensure, as if I can treat the patient over the, across the border.
Do you have answers?
Yes.
Okay.
I actually do a dementia clinic in the Pittsburgh VA, and we serve people in West Virginia and Ohio, as well as in Pennsylvania. In the VA, your license is good across the country, but our colleagues at UPMC can't treat people across the state border because they're a private or a non-federal institution. So that's the basic answer that, as far as I understand, and I have no idea about cross countries.
Yeah, I was going to say the same thing in Florida. We haven't looked at it in audiology, but in terms of actually training our students to eventually be able to practice telehealth, we've been looking into it for speech-language pathology. And I know if we were to provide services for Georgia, we'd have to get licensed there. I have one person doing it, and they had to qualify for the Georgia as well as the Florida license for SLP. So imagine audiology is the same.
Hi, I'm Tracy Lustig with the IOM, and to be self-promoting, I actually ran a workshop on telehealth in August of 2012, 2 days, very similar to this, and this was a huge issue that was discussed at that workshop. So there is a summary of that event that talks to it. I can't say there's an answer, but it's a big problem.
I am Juliette Sturkins, audiologist, and it ties in a little bit, but it's not perhaps the same. But Dr. Powers, as a physician, I don't know if you're aware of the telecoil law in the state of Arizona.
I'm not specifically aware of that. The hearing aids that we offer do not have the telecoil in it. In our small community, that's not a strong issue because we don't have any large performing arts centers or things like that that would require that. We do have on our bill of sale that it does say that it does not have telecoil technology in that hearing aid. So we've addressed it in that
Yeah,
manner.
because I think part of the counseling for the Arizona license is that you have to inform your clients that they are not getting a telecoil, which of course isn't just for performing arts centers, but it's for on the phone, it's for assistive technology, it's for neck loops. Without that telecoil, you can't access a lot of those other technologies.
I think you're exactly right, and that's, as you know, it's technology that is becoming more recognized, and I think probably in the future that these hearing aids will probably have that technology. They'll have to have it to stay up with the market. So I think that's good technology. It needs to be advanced, and we're informing the patients that at presently they don't have it. They sign it. We explain to it what it is, so they're well informed. There's no trickery. We're just trying to be honest and straightforward with them.
No, and I can tell that you're extremely passionate. I mean, it's the reason why I became an audiologist. So thank you.
Hi, my name is Wen Chen. I'm a program officer from the National Institute on Aging, and I applaud for all your wonderful talks today. I have a question. Just wanted to ask for your feedback and maybe a general assessment about the feasibility of the fact that whether we could do something similar to what people are doing with blood pressure. Like there's all sorts of monitors, remote monitors, very, like I have a blood pressure monitor at home for my father, and he, if he's not feeling well, he's going to measure whether he's got some blood pressure problem, whether he should, if the blood pressure is very high, he would go to see his doctor. And whether it's possible to do something similar for hearing, that people could, am I hearing right? Is there any simple device they could just quickly check at home? And then also with hearing aids that they would get, they could have something more, a more sort of objective feedback. They could see that, okay, this is not working very well. I should go to see a doctor and get it fixed.
Yeah, well, listen, so, there are ways you can monitor your own hearing just sort of informally, and we can validate those apps. We have, where I work at the VA, developed something that's for ototoxicity monitoring. So it's a way of taking home and doing a high-frequency audiometry at home to monitor people who are on chemotherapy, because chemotherapy, if the dose is too high, it can start to damage the hair cells, and you lose your hearing in the higher frequencies. And if you can change the regime before that sets in, then you can save somebody's hearing. So those, we're trying to integrate that into the system as well. So yes, you absolutely can. Hearing aids do collect data right now. There's data logging with hearing aids, how much you wear them. Seems like it would be very easy for people to be able to, probably industry is doing this, where you can actually collect data and then automatically send it to a manufacturer or an audiologist who could then make tweaks to the hearing aid, etc. So I think these are entirely possible.
They can even adjust it remotely too?
Yep, you absolutely can ingest it remotely.
I'm going to ask Gabby also to address Gabby's done some really interesting work on hearing loss prevention, where they have these kiosks that you can go into and then get education. And I think you can do that same model for looking at it for hearing screening within. So why don't you address that? Sorry.
Sure.
But
Okay,
talk
yeah.
into that, otherwise it doesn't link to the loop.
Okay. I'll move forward. Yeah, so we developed, it's more of an education and screening system, so people will take notice of their hearing and learn to protect their hearing from high levels of noise. But we had these booths located at a VA center and also in a couple of Army medical centers. And people use that and people can track their hearing. Now, we haven't set it up so you could have some kind of account so you can monitor your hearing over time. I think that would be ideal, and we've never wanted to go there because of all the PHI and encryption issues, but I think that's the next thing. I would suggest that probably rather than physical booths, we should be doing this stuff online or remotely because it is that much more accessible to more people and more frequently. So I think it's a wonderful idea, and we should. In fact, we want to do that. We want to take our hearing conservation program and put it online so more people can access it.
Yeah, I agree. I think that technology probably is coming. It's just come to the physician's level at this point in time where a physician can afford an audiometer. Prior to this, it was just too cost prohibitive. So now that we can afford it, you know eventually it's going to come to the home market. But it's probably going to be a little bit of time. We go out into the community and we go to the community health fair and we'll provide free hearing screening out in the community. But if you're a patient of mine, you're going to get screened anyway if you come to the office. So we got you covered.
I just want to add to that about putting things online. I think one of the nice features of that is that you can begin to tailor the content to the individual who's using it because you can have different modules. So somebody who comes on who's got a milder hearing loss might see a different range of education and recommendations than somebody who has normal hearing or a moderate hearing loss. So I think that's not something that's come up yet, is tailoring and targeting interventions. But I think that's a great way to go.
This is probably a whole other big topic, but I think, one of the ways in which audiology could mature is to really be more assertive in terms of interprofessional cooperation. And I think especially when we talk about older people, and so many older people who have hearing problems, I worry about, and I've heard so many people with hearing loss talk about, when they had to go to get their knee surgery and they had to leave their hearing aid, outside, and all of these atrocities of hard of hearing people participating in other health interventions which are not audiological interventions. So I'm just kind of curious for Gabby and for Dr. Powers. Now you know what your patient's hearing is like. Has that changed how you deliver health care to them when they have other problems? When they go for their surgeries, do you set it up so that their experience is more communication accessible? And for Gabby, there is so much e-health going on. Hard of hearing people, you go to the Toronto General Hospital, to any one of the tertiary clinics, and you want to come back for a follow-up, they'll say, will that be an in-person or an e-health appointment? So, what do they do if it's a hard of hearing person? And what are the accessibility issues? And is this an opportunity for us to establish actually much better relationships in terms of getting it right so that people with hearing loss get all the rest of their health care in a much more accessible fashion?
I'm on board with you. I think you're right. I think it's, if a physician, if you're treating back pain and you've had back pain yourself or back surgery, you have a lot of empathy for that patient and you can, give them a lot of help. I think it's very true with the hearing loss. Our community health trust in town, that's an organization which provides low-cost mammograms, low-cost lab tests. They also offer a virtual dementia tour. And I took my staff over there one day at lunch, and they give you a visual impaired device, they give you an auditory impaired device, they impair your tactile and your dexterity, and you go into a room and they give you 5 tasks to do. And boy, these 5 tasks, they're simple things like setting a place for 4 people, maybe writing 3 sentences to your family, picking a sweater out of a certain color sweater out of a pile of clothes. And to do these simple things were extremely difficult. And so it gave myself an idea of what dementia is, and my staff an idea. So when these older people come in, how do you respond to them when they don't understand when their appointment was, or they mix up their appointments or whatever? They have a much better understanding. And so I think, with us treating this hearing loss, they do have a better perception. And you're right, we need to be doing a better job about making sure that people can maintain their hearing during certain procedures and things like that. So I think it helps to be able to experience these things, and you can be much more empathetic with the patient.
Yeah, and I mean, clearly it would seem that communication that is conducted by email or through various messaging systems for the hearing impaired person is a huge opportunity. I mean, I think the one thing that's kind of ironic is that, as this is moving forward, so are privacy issues that make it more and more difficult legally to be communicating with people by email and such like. And it's kind of unfortunate that, the opportunity is open and yet it's closing in another way. So we need to figure out how. I heard an NPR article about on the Consumer Electronics Show talking about all these wonderful monitoring devices. But what the article focused on was patient privacy and how nobody who's developing these things was taking any notice of patient privacy. One of the developers said, well, my philosophy is let's develop the device, find out what we can do, and then put in the patient privacy. And, it's kind of a pull and push, I think, as to how we should go about it.
Good afternoon, James Appleby with the Gerontological Society of America, and thank you very much for all your presentations. Dr. Powers, I wanted to just make a comment about what I wonder what will happen in your community over time around the issue of stigmatization. If every patient who's coming in is suddenly getting screened, suddenly it's not a big ordeal next year and the year after that. Well, it's just what we do. We take blood pressure, take temperature. Oh yeah, we check, screen for this as well. And so I would applaud you for that, and just encourage, as we're thinking about over the 2 days, sort of what additional steps we can do to keep pushing towards primary care, coming up with a way to begin to introduce this as part of the normal routine, as a way over time to eliminate the stigma that comes with it. And really there's an analogy, you mentioned dementia a few moments ago, to the issue of the annual Medicare wellness visit, in which we're to be detecting cognitive impairment, and yet we've never been able to put it in place in primary care that I'm aware of, except for some isolated cases, a regular mechanism to do it that doesn't in some way create all sorts of fears, concerns, et cetera, among patients. I just encourage us to even think about that as well, around if every patient, when they're coming in for their annual wellness visit, it's just what you always do. Oh yeah, we do. We take the short assessment or detection experience, whatever it is, then being detecting cognitive impairment wouldn't be such a terribly scary thing. So I think there's a lot of analogies between what you're doing here to eliminate stigma and what we can also do in other areas that in particular affect the older adult population. So thank you.
Just kind of, somebody asked about screening. I think screening in physicians' offices should be something that we should not look lightly on. So when I first started at UM about going on 4 years, one of my first goals were to go to internal medicine and insist that everybody over the age of 45 were screened. And what we did was just use a handheld. It was already preset 20, 40 decibels, and it's either you heard it or you didn't. I was just looking at my data. Since December 2010, we've actually caught 6 acoustic neuromas and 4 NSF tumors. These are people who had just absolutely had no idea, but there was an asymmetry, there was a bilateral. So they did identify this, and now with the app, which I just pulled it up, there's a hearing test in here, and we've actually gotten all the physicians on their iPhones to have the same app, and they just do it. So it is part of the well-being, just like we talk about. You know, this is part of you know, societal problems that we are going to have to face with eventually, and this is getting more and more. It's not the 80s and the 90s, people. It's, you know, we're starting to see hearing loss much, much earlier. Life is no longer linear, and these people need to, you know, be stimulated today. And Avance, Resound came out back in the 80s with the most phenomenal little, you know, $300 hearing aid to help and we fit a lot of these physicians and with people with these, you know, very mild high frequency. It was the beginning, and then Songbird came out. Just like we have cheaters, you know, we buy cheaters because we can't see it. So Dr. Powers, I commend you for what you're doing, because I think a lot of people are being missed. And those folks who potentially come back and have severe problems, and you're going to refer them on, and you're going to screen them. You're going to make sure that they're, you know, medically and FDA guidelines. But I think that their screening in medical and primary cares, it needs to happen. This is part of our health. I really do.
I agree. I mean, what if I, as a physician, didn't do blood pressure checks on everybody that came in? Boy, the medical board, my malpractice care would be all over me. And so hearing is the same. It's an important, vital sign that we should be taking. And for whatever reason, it's gotten lost, and it's going to take re-education. I think the American Academy of Family Physicians need to re-educate, the American Academy of Internists. I think they all need, it's simple. It's not a big cost to do a screen. It's not time consuming. It's a simple little device to screen. Now to test, you know, there's going to be a little more by the audiometer and all that. But for screening, it should be widespread and done every time a blood pressure or a pulse is taken.
Yeah, and I'd just like to echo Sergio's comment about people being unaware. You know, people liberally throw around the word patients in denial, but I often think it's simply a lack of awareness. And you know, by screening somebody, you will see that change. They may not perceive it, but it will be something that can be documented. Yes, your hearing has changed. So I don't know, I think we should limit use of the word denial and think of it often as just simply a lack of awareness, because this hearing loss has been so gradual over time.
It's Chris Roberts, Cochlear. It's been a really great day. And when we think about age-related hearing loss, we've learnt today, we've gone through that it's a peripheral problem as well as a central problem. And the central problem is not just the auditory cortex processing, but it's higher executive order functioning as well, cognition. And we have at our hands some technology and improving technology to help with the periphery. But I think there's also profound increases in our understanding about what's happening, what we can do centrally. And probably the huge opportunity we have is the understanding that the aging brain can remain as plastic as it ever was. And what we have to do is take advantage of that plasticity. And I think the discipline we still need to embrace is neuroplasticity, the advances taking place there. And my question is really to Gabrielle and Lace. So it doesn't surprise me if you do a sort of population sort of auditory training that at a population level you don't show much, because I still don't think we're really embracing the fundamental principles of neuroplasticity, but you will in some of those people. You need focused attention and things. So it also doesn't surprise me that you get big effects in some of those patients. But my question is, what was your take from your experience with LACE, and where are you thinking in terms of what we should be doing centrally to be more active?
Okay, well, as it happens, Terry was a co-conspirator on that grant. So we both came out, I mean, I came out of that thinking, okay, we need to be able to predict some way or other who is going to benefit and who is not. We don't know how to do it. Another thing about our particular study is our subject population were all veterans. And it strikes me that they have, many of them at least, have had hearing loss for 40 years. if they had lost some hearing from their military service. So why we would expect 4 weeks of auditory training is going to fix 40 years worth of hearing loss is beyond me. I think, that is not a realistic expectation. We have talked about doing a study. Well, let's involve the patient in the decision to do the training. If they believe it, if they're motivated, maybe that's the way to go. That is going to be the best predictor of outcome, is that patient desire to participate. Carrie, have you got something to add?
Lou's trying to mouth something to me, and I wanted. No, that's not the one where we used to. We did another study with TBI patients. Yeah, Gabby and I, so one of the things we were kind of interested in looking at is involving the patients, because I think until we get the diagnostic tools to say, okay, you need to work on speeded speech, because that might help you because you have some sort of problems following that, or you need to, it's the attention issues, divided attention, selective attention. We really don't have the tools to quickly do that. But I think that there are options that you could do to let the person self-guide to a certain extent about what they perceive they're getting benefit from. The interesting thing about the LACE study with our 279 patients and the population level not having it is that if you talk to the patients, they still loved it. So they're getting something out of it. Maybe we're increasing their confidence, and we don't know what the role of increasing confidence is in later on communication. So they're liking it, but we don't know exactly we can't measure at that group level what's changing. Yeah.
Frank, can I just make one other comment just on this? So the other thing when we think about neuroplasticity, though, if we look at a biologic level and what's happening with neurotransmitters and the like, it's clear that a lot of medication that these people are on can have profound effects that can be negative effects on neuroplasticity. And I think somehow we have to be thinking about what medication these people are on as well. And I'm not sure what your thoughts are on it.
Right, and we did not look at that. I think we do have comorbidities, the number of comorbidities, and we can go back and look at that. But whether or not there's medications, that's a good point that we did not take into account. I think there was some work done with cochlear implants, actually looking at some medications that enhance training. Do you remember that? That was done in Miami or, yeah.
Texas, right?
Texas,
With,
at Calumet, at Dallas, where they actually did medications enhance the auditory learning.
Emily Tobey gave
deamphetamine.
Yeah,
Emily Tobey did that work. Yeah.
Yep.
So. Oh man, you can't. Darn.
So on that last point, I want to finish the session and thank all our speakers again. After